the beating in your chest is a good thing. Smarter Heart University and Dr. Scott on AM 970, The Apple.
Welcome back and good morning to your Smarter Heart University. Yes, the beating in your chest is a good thing as long as it's regular. Answer to the pop quiz. If you drink either a case of beer or 35 mixed drinks a week, and I don't know how people do that, but what is your chance of getting atrial fibrillation? 15%, 45%, or 75%? The answer is actually 45% chance of getting atrial fibrillation over non-drinkers completely. Now, what's interesting is moderate alcohol intake, we've always talked about moderate, and we're going to do a whole show on that, does not increase the risk of atrial fibrillation. So it's about 3 drinks a day, which American Heart really would rather you do 1 to 2. Really, once 4 drinks a day is consumed, off to the races you go.
Yeah,
so
holiday
that's
heart.
Holiday heart syndrome. And, around Christmas time, all the emergency medicine doctors listening and all the cardiologists, we get called in a lot for that particular rhythm. On our line is Mr. Dave Berger. Hi, Dave.
Good morning.
How are you? Dave,
I'm very well.
Why don't you tell us a little bit about yourself?
All right. Well, I am 54 years old, and I've had atrial fibrillation, or AFib as it's commonly called, since 2001. Have been functioning fairly normally with it for, almost 10 years now. And I, other than that, I'm very, very healthy, exercise daily. Obviously, I work full-time, and as you said, I run this support group on Facebook.
You had talked to me about the lone atrial fib aspect. As you have it, so you've done your education, and you're the moderator, and I've actually listened to your site. And watched your site and over the past couple of weeks just to watch all the other contributors. And, it's interesting because a lot of people, as you said in your email back to me, suffer from this. And as you stated very well, suffer from this worse than you. And I think that's a great point because there's such a variability in this particular disease process. And it really is a disease process. One question, Dave, anybody in your family have it?
Actually, no. No one in my family. My dad's passed. My mom's still alive. I've got 2 other brothers and a sister, and I am the only one in the family that has atrial fibrillation.
Interesting. Well, stay with us for a second. I just want to touch on our topic for this segment. After we thin the blood, we have to slow the heart rate down. So you said you had a couple of instances where you had to be in the emergency room and you had to get medication. So once we slow that heart rate down, and we'll talk about that in the next segment, we have to decide on whether or not we want to leave you in that rhythm. If it's the best thing, or it makes no difference to leave you in an irregular rhythm that's controlled, or to convert you to a regular rhythm, either quickly or delay that. And that's really the bottom line is that anytime anybody comes into an emergency room with this, that those are assessed, but every single time it's pretty much straightforward. What everybody out there needs to know, bottom line, is it doesn't matter whether we keep you controlled in that irregular rhythm or we try to convert you to a regular rhythm. As long as your blood is thinned at the right level, there's no stroke for you. Now, back to you, Dave. You're on an aspirin or on Coumadin?
I'm on a baby aspirin daily.
Right.
I also take Flecainide,
Uh-huh.
and that's a low dose of 50 milligrams daily.
Right. So for our listeners, Dave is on what we call an antiarrhythmic drug. That's a medication that actually suppresses the atrial fibrillation and converts it, or keeps it from converting into an irregular rhythm. And it's also used to convert somebody from the irregular rhythm back to a regular rhythm. It can be used either way, and we often use those 2 medications. And the young lady that blogged last night on her discussion forum, I actually answered her back because she asked me what's so important about her drug as well as the Flecainide that you're on. I assume you're on something beta blocker, metoprolol, or something else?
Yes, 25
There you
milligrams
go.
daily.
And the reason is because that's a rate control medication, and we often give it with certain of these drugs. As long as structurally your heart is normal, we do an echocardiogram, which is an ultrasound, and as long as that's the case, Dave falls into this low score. So he's either a 0 or a 1 score, and in those scores, we can give him aspirin and safely say Dave's not going to have a stroke if he should have this. So Dave's on a medication to prevent him from becoming irregular, and he's on a medicine to keep his heart rate down. But what we want our listeners to understand, what the American College of Cardiology and the American Heart Association has put forth, it's the silent part that you don't know, that you don't feel, and unless we do monitors, and we do them in our office, all cardiologists do, either 24 or 7 or 10-day monitors to be able to assess that. Well, why convert somebody if we can't control your rate, if you can't tolerate the medications, if you can't tolerate the rhythm due to those symptoms we talked about, the dizziness, the passing out, the chest pain, the shortness of breath, or if your heart gets weaker from this, because these rhythms can cause your heart to get weaker. We want to restore you back to regularity. How do we do that? Pills, shocks, or freezing? Any comment there, Bob?
Well, I have a perfect patient who had that very syndrome. He really had no symptoms of atrial fibrillation. He came in with an abnormal EKG, and we did an echocardiogram and showed that he had a weak heart. And in that situation, he was going way too fast for way too long, and it damaged his heart. The good thing is that once we get control of that and get control of his heart rate, and it actually ended up having to be surgery to control it because of all the various things that went on with him. We're now 6 months out, and his heart pumping function has returned to normal. So that's a clear reason why we need to, in some situations, get aggressive with that.
And Dave, have you on your support forum? And I urge everybody, and Dave, you can give that full name and talk about it. I urge everybody who has had this irregular rhythm or continually has this. I'll go back and forth now and look and see if I can make a contribution to his forum from time to time now. Because as I said, I'm watching it. Have you seen a lot of people asking questions that are hard for you to answer, or where do you get? Do you have a lot of physicians that are actually helping out as well?
Well, predominantly the contributors are obviously members of the Facebook page, and they have suffered in some way, some shape with atrial fibrillation, whether they've had a cardioversion, or they've had an ablation, or a catheterization, or they just have lone atrial fibrillation, as I do. We have some terrific people with some incredible experiences that they share and answer the other questions that come about from those that say, well, I'm new to the site, or I just experienced my first episode, and then these members with the experience of 2, 3, 4, 8, 10, 15 years jump in and are very, very helpful.
Yeah, I noticed that. And as I said, that's why I urge everybody, because it's a support group. You're suffering, and you've got other people that have this and can give their opinions, what their physicians has done for them. And remember, folks, we're not here to offer an opinion about it. We're here to talk about what's evidence out there in medicine, and to give you the ability to understand things better and help your doctor help you understand things better. That's the most important thing. And you know what? Patients can help other patients understand things better as well. In the interest of time, we can't discuss all the medications that we could use. It would take an hour. We start with medications that slow and control your rate, as Dave was talking about, and he's on. If it fails, we can chemically try to convert you, as Dave has, and he's on a medication. And some of these have a lot of side effects. If these fails, we can put an ultrasound probe down your esophagus, perform like an endoscopy looking for an ulcer, but a smaller tube, 5-10 minutes, really doesn't take long. You're sleeping, and this allows us, because the heart's behind the esophagus, to go 360 degrees and make sure there's no clots. While you're sleeping, we deliver a little shock, and it may or may not convert you back to a regular rhythm. Or we can place you on Coumadin, warfarin, for 3 weeks. Once your blood is thinned, we deliver a shock as a same-day admission. You come back into the hospital, and you get that shock and put you back to a regular rhythm. Before I go forward, let's give you the pop quiz for the next segment. Who does worse with atrial fibrillation in terms of life and death as well as stroke, men or women? Who does worse? The important point to note is in terms of the which method to use is based on the patient. So this gentleman that's in the hospital today that I'm going to see after this broadcast, if he converts because maybe it was just adrenaline that kicked him up and triggered it, as we talked about. If he converts, we send him home.